Hi, my name is Rachel, and when I was 24 years old, I started experiencing spontaneous itch and hives. I would come home and would start to see hives popping up on my arms and legs. They weren't painful, so I would typically ignore them or take an antihistamine and they would go away. But over the course of the next year, they started to increase in number and become more severe. I wasn't comfortable showing my skin, and I had to wear loose clothing to prevent irritation. It made me tense because I worked in fashion where there's a lot of physical interaction, and I didn't want anyone thinking I was contagious.
I'm Dr. Sandra Gottschalk. For those not living with CSU, including us as healthcare practitioners, it's hard to comprehend how frustrating CSU can be. Patients with CSU can find the condition difficult to live with, and the symptoms can be irritating and uncomfortable. In my practice, approximately 90% of my patients with CSU are female. They've seen several doctors in the hope of finding answers, and they've heard everything. It could be stress, allergies, or all in their head. This can be incredibly defeating for a patient who has been suffering from itch and hives.
When I went to my general practitioner, she threw her hands up in despair. This general practitioner could not figure out what was wrong with me. At first, we thought it might be an infection or stress-related. We even thought it was lupus, since that runs in my family. After years of what felt like a revolving cycle of specialists and doctors, I finally met one who diagnosed me with chronic spontaneous urticaria. She told me sometimes there isn't a reason a person has hives. It's called chronic hives with no known cause because there's no underlying cause. Although I was diagnosed, finding relief remained a challenge. I was prescribed H1 antihistamines, and at one point, my treatment plan had me taking many pills throughout the day. Even with all those pills, relief was only temporary and sometimes minimal. It wasn't until my doctor told me about XOLAIR that I learned what's possible for my CSU.
Treating CSU is a team effort. Each patient has their own unique struggle with CSU, and understanding that experience is important when working together. So I want to know more about them. What is their disease history? Have they identified any triggers or comorbidities? How are they feeling? What are their hopes for treatment? I want them to be part of the process, for them to understand their condition and the options available to them. When a patient comes to me with CSU, I start them off on H1 antihistamines. I let them know that the goal of those is to be almost completely itch and hive free. But in the event of reoccurrence or when H1 antihistamine therapy isn't enough, there are other options, such as XOLAIR.
I want my doctor to treat me more like a partner, not a patient. I'm a big believer in teamwork and being involved in the process. When I'm included in my care, I'm engaged and optimistic. Like my doctor factors my feelings into decisions. I know what my options are and what the journey looks like.
When patients learn that options like XOLAIR exist for treating CSU, then they know that relief may be possible. By working together, communicating, and understanding the needs of CSU patients, we can help them find relief.
XOLAIR, omalizumab. Indication and important safety information.
Indication. XOLAIR, omalizumab, is indicated for the treatment of chronic spontaneous urticaria, CSU, in adults and adolescents 12 years of age and older who remain symptomatic despite H1 antihistamine treatment. Limitations of use. XOLAIR is not indicated for treatment of other forms of urticaria. Important safety information. Warning: anaphylaxis. Anaphylaxis presenting as bronchospasm, hypotension, syncope, urticaria, and/or angioedema of the throat or tongue has been reported to occur after administration of XOLAIR. Anaphylaxis has occurred as early as after the first dose of XOLAIR but also has occurred beyond 1 year after beginning regularly administered treatment. Because of the risk of anaphylaxis, initiate XOLAIR therapy in a healthcare setting and closely observe patients for an appropriate period of time after XOLAIR administration. Healthcare providers administering XOLAIR should be prepared to manage anaphylaxis, which can be life-threatening, inform patients of the signs and symptoms of anaphylaxis, and instruct them to seek immediate medical care should symptoms occur. Selection of patients for self-administration of XOLAIR should be based on criteria to mitigate risk from anaphylaxis. Contraindications. XOLAIR is contraindicated in patients with a severe hypersensitivity reaction to XOLAIR or to any ingredient of XOLAIR. Warnings and precautions. Anaphylaxis. Anaphylaxis has been reported to occur after administration of XOLAIR in pre-marketing clinical trials and in post-marketing spontaneous reports. In pre-marketing clinical trials in patients for a different indication, anaphylaxis was reported in 3 of 3,507, 0.1% patients. Anaphylaxis occurred with the first dose of XOLAIR in 2 patients and with the 4th dose in 1 patient. The time to onset of anaphylaxis was 90 minutes after administration in 2 patients and 2 hours after administration in 1 patient. A case control study in asthma patients showed that among XOLAIR users, patients with a history of anaphylaxis to foods, medications, or other causes were at increased risk of anaphylaxis associated with XOLAIR compared to those with no prior history of anaphylaxis. In post-marketing spontaneous reports, the frequency of anaphylaxis attributed to XOLAIR use was estimated to be at least 0.2% of patients, based on an estimated exposure of about 57,300 patients from June 2003 through December 2006. Approximately 60% to 70% of anaphylaxis cases have been reported to occur within the first 3 doses of XOLAIR, with additional cases occurring sporadically beyond the 3rd dose. Initiate XOLAIR only in a healthcare setting equipped to manage anaphylaxis, which can be life-threatening. Observe patients closely for an appropriate period of time after administration of XOLAIR, taking into account the time to onset of anaphylaxis seen in pre-marketing clinical trials and post-marketing spontaneous reports. Inform patients of the signs and symptoms of anaphylaxis and instruct them to seek immediate medical care should signs or symptoms occur. Once XOLAIR therapy has been established, administration of XOLAIR pre-filled syringe or autoinjector outside of a healthcare setting by a patient or a caregiver may be appropriate for selected patients. Patient selection, determined by the healthcare provider in consultation with the patient, should take into account the pattern of anaphylaxis events seen in pre-marketing clinical trials and post-marketing spontaneous reports, as well as individual patient risk factors, e.g., prior history of anaphylaxis, ability to recognize signs and symptoms of anaphylaxis, and ability to perform subcutaneous injections with XOLAIR pre-filled syringe or autoinjector with proper technique, according to the prescribed dosing regimen and instructions for use. Discontinue XOLAIR in patients who experience a severe hypersensitivity reaction. Malignancy. Malignant neoplasms were observed in 20 of 4,127, 0.5% XOLAIR-treated patients, compared with 5 of 2,236, 0.2% control patients, in clinical studies of adults and adolescents greater than or equal to 12 years of age for a different indication and other allergic disorders. The observed malignancies in XOLAIR-treated patients were a variety of types, with breast, non-melanoma skin, prostate, melanoma, and parotid occurring more than once, and 5 other types occurring once each. The majority of patients were observed for less than 1 year. The impact of longer exposure to XOLAIR or use in patients at higher risk for malignancy, e.g., elderly current smokers, is not known. A subsequent 5-year observational study of 5,007 XOLAIR-treated and 2,829 non-XOLAIR-treated adolescent and adult patients for a different indication found that the incidence rates of primary malignancies per 1,000 patient years were similar in both groups, 12.3 versus 13.0 respectively. Study limitations, which include the observational study design, the bias introduced by allowing enrollment of patients previously exposed to XOLAIR, 88%, enrollment of patients, 56%, while a history of cancer or a pre-malignant condition were study exclusion criteria, and the high study discontinuation rate, 44%, preclude definitively ruling out a malignancy risk with XOLAIR. Corticosteroid reduction. In CSU patients, the use of XOLAIR in combination with corticosteroids has not been evaluated. Fever, arthralgia, and rash. In post-approval use, some patients have experienced a constellation of signs and symptoms, including arthritis, arthralgia, rash, fever, and lymphadenopathy with an onset 1 to 5 days after the first or subsequent injections of XOLAIR. These signs and symptoms have recurred after additional doses in some patients. Physicians should stop XOLAIR if a patient develops this constellation of signs and symptoms. Parasitic helminth infection. Monitor patients at high risk of GO-helminth infection while on XOLAIR therapy. Insufficient data are available to determine the length of monitoring required for GO-helminth infections after stopping XOLAIR treatment. Laboratory tests. Due to formation of XOLAIR IgE complexes, serum total IgE levels increase following administration of XOLAIR and may remain elevated for up to 1 year following discontinuation of XOLAIR. Potential medication error related to emergency treatment of anaphylaxis. XOLAIR should not be used for the emergency treatment of allergic reactions, including anaphylaxis. In studies to simulate use, some patients and caregivers did not understand that XOLAIR is not intended for the emergency treatment of allergic reactions, including anaphylaxis. The safety and effectiveness of XOLAIR for emergency treatment of allergic reactions, including anaphylaxis, have not been established. Instruct patients that XOLAIR is for maintenance use to reduce allergic reactions, including anaphylaxis, while avoiding food allergens. Adverse reactions. Chronic spontaneous urticaria. The most common adverse reactions, greater than or equal to 2% incidence in XOLAIR-treated patients and more frequent than in placebo, for XOLAIR 150 mg and 300 mg respectively, included headache, 12%, 6%, nasopharyngitis, 9%, 7%, arthralgia, 3%, 3%, viral upper respiratory infection, 2%, 1%, nausea, 1%, 3%, sinusitis, 1%, 5%, upper respiratory tract infection, 1%, 3%, and cough, 1%, 2%. Injection site reactions. Injection site reactions of any severity occurred in more XOLAIR-treated patients, 11 patients, 2.7% at 300 mg, 1 patient, 0.6% at 150 mg, compared with 2 placebo-treated patients, 0.8%. The types of injection site reactions included swelling, erythema, pain, bruising, itching, bleeding, and urticaria. None of the events resulted in study discontinuation or treatment interruption. Injection site reactions in healthy adults. In an open-label trial in healthy adults, in which the 300 mg 2 ml autoinjector was compared to the 300 mg 2 ml pre-filled syringe, injection site reactions, e.g. induration, pain, erythema, hemorrhage, swelling, discomfort, bruising, hypoesthesia, edema, pruritus, were observed in 24%, 16 out of 66, of subjects treated with the autoinjector, compared with 14%, 9 out of 64, of subjects treated with the pre-filled syringe. Cardiovascular and cerebrovascular events from clinical studies for a different indication. A 5-year observational study was conducted in 5,007 XOLAIR-treated and 2,829 non-XOLAIR treated patients, greater than or equal to 12 years of age for a different indication, to evaluate the long-term safety of XOLAIR, including the risk of malignancy. Similar percentages of patients in both cohorts were current 5% or former smokers 29%. Patients had a mean age of 45 years and were followed for a mean of 3.7 years. More XOLAIR-treated patients were diagnosed with a severe form of the condition studied, 50%, compared to the non-XOLAIR-treated patients, 23%. A higher incidence rate per 1,000 patient years of overall cardiovascular and cerebrovascular serious adverse events, SAEs, was observed in XOLAIR-treated patients, 13.4, compared to non-XOLAIR-treated patients, 8.1. Increases in rates were observed for transient ischemic attack, 0.7 versus 0.1, myocardial infarction, 2.1 versus 0.8, pulmonary hypertension, 0.5 versus 0, pulmonary embolism, venous thrombosis, 3.2 versus 1.5, and unstable angina, 2.2 versus 1.4, while the rates observed for ischemic stroke and cardiovascular death were similar among both study cohorts. The results suggest a potential increased risk of serious cardiovascular and cerebrovascular events in patients treated with XOLAIR. However, the observational study design, the inclusion of patients previously exposed to XOLAIR, 88% for a mean of 8 months, baseline imbalances in cardiovascular risk factors between the treatment groups, an inability to adjust for unmeasured risk factors, and the high study discontinuation rate, 44%, limit the ability to quantify the magnitude of the risk. Pregnancy. Data with XOLAIR use in pregnant women are insufficient to inform on drug-associated risk. You may report side effects to the FDA at 800-FDA-1088 or www.fda.gov/medwatch. You may also report side effects to Genentech at 888-835-2555 or Novartis Pharmaceuticals Corporation at 888-669-6682. Please see full prescribing information, including boxed warning and medication guide, for additional important safety information.